Hi everyone and welcome back to the channel. I'm Professor Shebu Orichabello, and in today's lecture we're tackling one of the classic antibiotic families you absolutely need to master: the aminoglycosides. Whether you're a medical or pharmacy student prepping for exams or brushing up for the wards, stick with me. Over the next few minutes we'll cover how these drugs work, when we reach for them, the toxicities that make them tricky, and the mnemonics that will lock it all into memory. Let's get started. So what exactly are aminoglycosides? At their core, these are potent, broad-spectrum bactericidal antibiotics. And that bactericidal part matters because most protein synthesis inhibitors only stop bacteria from growing. They come from soil organisms. The ones ending in mycin come from streptomyces, and those ending in mycin come from micromonospora. Streptomycin, discovered back in 1944, was the very first, and it was also the first effective drug against tuberculosis. Two features to hold on to here: they kill in a concentration dependent way, and they have a narrow therapeutic index, which is exactly why dosing and monitoring have to be spot on. Let's meet the family. Gentamicin is your everyday workhorse for gram-negative sepsis and a key player in endocarditis synergy. Tobramycin shines against Pseudomonas and comes in an inhaled form for cystic fibrosis. Amikacin has the broadest coverage and resists the enzymes bacteria use to destroy these drugs, so we save it for resistant bugs. Streptomycin is our TB and zoonotic infection agent. Neomycin is too toxic for the bloodstream, so we keep it topical or oral. And plazomicin is the newer agent for resistant urinary infections. Here's the mnemonic that ties it together: J through gentamicin, neomycin, tobramycin, streptomycin. Picture a swarm of gnats and you've got the whole class. Now, how do they actually work? Follow the 4 steps on screen. First, the drug has to get inside the bacterium, and that uptake needs oxygen. Remember that, it explains a lot later. Once inside, it binds irreversibly to the 30S subunit of the ribosome and blocks the initiation complex from forming. Then it causes the ribosome to misread the messenger RNA, so the bacterium churns out faulty, nonsense proteins. Finally, it jams translocation and protein synthesis grinds to a halt. The net result is rapid, concentration-dependent killing. Quick mnemonic by 8030, aminoglycosides and tetracyclines both act at the 30S subunit. Pharmacokinetics next, and this is where a lot of the clinical behavior comes from. Aminoglycosides are polar cations, so they're barely absorbed from the gut. That's why we give them intravenously or intramuscularly for systemic infection, and only use oral or topical neomycin and paramomycin when we want a local effect in the bowel. They don't penetrate tissue or spinal fluid well, they aren't metabolized, and they're cleared unchanged by the kidneys, so renal function drives your dosing. On the pharmacodynamic side, killing is concentration dependent with a long post-antibiotic effect. The takeaway: hit hard and hit high. Aim for a peak about 8 to 10 times the MIC. Let's talk coverage. The sweet spot is aerobic gram-negative bacilli: E. coli, Klebsiella, Enterobacter, Serratia, Proteus, and importantly Pseudomonas. We also lean on synergy, pair them with a beta-lactam or vancomycin, and that cell wall agent opens the door, letting the aminoglycoside get in to tackle gram-positives like enterococci in endocarditis. Streptomycin and amikacin also hit mycobacteria. But here's the big limitation. They do not cover anaerobes because remember, uptake needs oxygen. The mnemonic ties it up neatly, mean GNATs cannot kill anaerobes. So when do we actually reach for these drugs? Number 1, serious gram-negative infections, sepsis, complicated urinary infections, hospital and ventilator-associated pneumonia, and intra-abdominal infections. 2, a synergistic combination therapy added to a beta-lactam or vancomycin for enterococcal and streptococcal endocarditis. 3, Pseudomonas, where tobramycin, including the inhaled form, is a mainstay in cystic fibrosis. 4, mycobacteria and zoonoses like TB, tularemia, plague, and brucellosis. And 5, the local, non-systemic uses oral neomycin for bowel prep and hepatic encephalopathy, and paramomycin for intestinal amoebiasis. Dosing is where you can really show clinical maturity, and there are 2 strategies. Extended interval or once daily. Dosing gives a big single dose, usually 5 to 7 milligrams per kilogram. It takes advantage of that concentration-dependent killing, and the post-antibiotic effect tends to be less toxic, and we monitor it with a nomogram using a single level. The traditional approach splits smaller doses every 8 to 12 hours, and we still prefer it in specific situations. Endocarditis, pregnancy, burns, pediatrics, and unstable renal function, monitoring with peaks and troughs, whichever you choose. Dose by weight, use ideal or adjusted body weight in obesity, and always match the interval to creatinine clearance. Why do these drugs sometimes fail? 3 main mechanisms. The most common and clinically important is aminoglycoside modifying enzymes. Acetyl phospho and nucleotidal transferases, usually carried on plasmids that chemically inactivate the drug. Second, bacteria can simply keep the drug out by altering membrane permeability or pumping it back out with efflux pumps. And third, they can change the target itself, methylating the 16S ribosomal RNNA or mutating the ribosome so the drug can't bind. One clinical pearl worth remembering, amikacin resists most of those modifying enzymes because it has the fewest sites for them to attack, which is exactly why we reserve it for resistant strains. Now the part that keeps prescribers up at night, toxicity. There are 2 big ones. Nephrotoxicity, injury to the proximal tubule, seen in roughly 10 to 25% of patients. The good news is it's usually reversible. Ototoxicity is more feared because it's often permanent. It can hit the cochlea, causing hearing loss and tinnitus or the vestibular system, causing vertigo and imbalance. And some patients are genetically predisposed through a mitochondrial mutation. Then 2 more to know: neuromuscular blockade, rare but dangerous in myasthenia gravis or with anesthetics, and teratogenicity, so we avoid them in pregnancy. The mnemonic is simply not. Nephrotoxicity, ototoxicity, and teratogenic. because that toxicity is so real and the therapeutic window is so narrow. Therapeutic drug monitoring is essential. Think of it as two numbers. The peak drawn about 30 minutes after the dose finishes tells you about efficacy. Is your concentration high enough relative to the MIC? The trough drawn just before the next dose tells you about clearance and toxicity risk. A high trough means the drug is accumulating. For once daily dosing, we use a validated nomogram with a single random level, and beyond drug levels, check renal function regularly, get baseline and serial audiometry for long courses, and avoid stacking other nephro and ototoxins like loop diuretics, vancomycin, amphotericin B, and contrast. Alright, let's lock this in with a quick mnemonic recap. Honestly, screenshot this slide. First, the class itself sounds like aminoglycosides, and the drugs are your GNATs, gentamicin, neomycin, amikacin, tobramycin. The toxicities are not nephrotoxicity, ototoxicity, teratogenic, plus neuromuscular blockade. By 8030 reminds you that aminoglycosides and tetracyclines act at the 30S subunit. And finally, they need oxygen to get in, which is why they simply cannot kill anaerobes. 4 little phrases, and you've basically got the whole class. Let's bring it home. Aminoglycosides are bactericidal 30S inhibitors that kill in a concentration-dependent way. They are our go-to for serious aerobic gram-negative infections, and they synergize beautifully with beta-lactams. But they never touch anaerobes. They have a narrow therapeutic index, so dose by weight, adjust to renal function, and monitor closely. Respect the not toxicities. Especially remember that ototoxicity can be permanent. And in most patients, once daily dosing gives you the same efficacy with less harm. That's it for today. If this helped things click, give it a like, subscribe for more pharmacology, and drop your questions in the comments. I'm Professor Bello. Thanks for watching, and I'll see you in the next one.